시청자 여러분 안녕하세요.
Greetings. This is Prosthodontics on Friday, which addresses the different steps of prosthodontic treatment as well as its side effects. In 2023, under the grand theme Back to the Basics Full Denture, we have been providing lectures over the past half year, and in the latter half, we are also going to provide meaningful lectures under this topic. Today, we have with us Professor Lee Chung-hee of Gyeongbuk University Dental School under the title, Is the Use of Articulator Important in Prosthesis Fabrication? Greetings. Thank you for coming all the way here from Daegu. Thank you for inviting me. Professor Cho, I really look up to you and it's a great privilege to be with you. Can you provide a brief explanation as to what today's lecture is about to our viewers? I was asked to talk about articulators in fabricating full dentures. Articulators are explained fully in textbooks, but I want to talk about why we need to use articulators in terms of clinical aspect and why this is necessary. Thank you. After listening to you, I look forward to today's lecture even more. Those of you watching from Dental Site, you can participate via real-time chats. Leave your questions and have them answered, and you'll be able to win Starbucks coffee coupons. The person who leaves the most memorable question will be selected as best question, and Dental Music Tiger scent will be sent. Learn about full dentures and win amazing prizes. I look forward to your keen interest and participation, and let us begin Prosthodontics on Friday. Greetings, I'm Professor Lee Chung-hee of Prosthodontics Division at Gyeongbuk University Dental School. This is my first time being in a live program, so I feel a bit awkward. I hope you understand. Today I want to talk about the necessity of articulators in full denture fabrication. Clinically speaking, I want to share with you my opinion on full denture treatment. This is a topic that has been researched from very long ago, and almost all details are in the textbooks. It has been summarized really nicely, so please refer to the textbooks. Some people talk about how to find the easier and simpler way to get good results, but I think that's quite a meaningless effort because all steps need to be taken and mistakes made in each step can affect the end result, so you need to pay a lot of attention to each step. Third, patient's ability to adapt differ by patient. For instance, a patient might have received a treatment from a legal dental clinic, but still the patient may be fine. On the other hand, a different patient might suffer even though the dentist paid a lot of attention to the case. That's why full denture is so interesting. Should we do a rough job for patients with good adaptability and pay more attention to those who don't? I don't think that's it. We need to pay a lot of attention to each steps for every treatment to get optimum results. Sometimes the patient may be fine with it, but it may not be satisfactory under my own set of standards. And after improvement, the patient may be more satisfied. Regardless of adaptability, you need to do your best based on your knowledge and experience. Use of articulator in fabricating full dentures. I've talked about this before, but if you don't have articulator, I would not have dared to fabricate full dentures. This is imperative. In providing full denture treatment, articulators are an amazing tool that we need to use. What are the advantages of use of articulators? On the internet, it's written like this. Adequately articulated models allow the dentist to see the patient's occlusal relationship much more clearly, especially from the lingual side. When using an articulator, once a proper occlusal record is obtained, patient cooperation is not essential. We can do a good job even without the patient. Patient chair time can be reduced, and we can do it when patient's not there. It's the same with crown bridge as well. Improving full denture occlusion intraorally is extremely difficult because of the mobility of the prosthesis and elasticity of supporting tissues. After taking interarch relations intraorally, you can do it using articulator extraorally. I believe the fact that we need to use articulator extraorally is very important. Mounting can be done by lab technician. We can have others do it. Patient's saliva, tongue, and cheek do not affect the results. There are many advantages. The importance of use of articulator upon full denture fabrication. Let's take a closer look. Do we need to do face bow transfer? Is this really imperative? Second, what kind of articulator should I use, and when and where should I use it? I want to focus on these 2 points. Do we really need to do face bow transfer? This is the first topic. This is at initial visit. This is my staff's mother. I immediately noticed something awkward, and I asked the caretaker of the patient. I asked them whether they noticed something odd. Neither the patient nor the caretaker noticed how it was odd, but it was very apparent to me. The patient's focus was not on aesthetics and was on restoring mastication. I think this had to do with the patient's age, but from dentist's perspective, we need to make aesthetic results. So this is the restoration that I provided. This is the same patient. It's parallel here. Let's take a look at the maxillary denture. You can see there's difference between left and right. Why did I do this? Why did this kind of problem occur? This is patient's intraoral image. The canting that we observed earlier has been copied here. Why did this occur? This looks parallel here. The inclination is like this at the initial visit. There's inclination up to the middle. So inclined prosthesis came to be. Because I skipped the face bow transfer, this kind of problem resulted. I don't know whether this was done by someone illegitimate or by a lab technician. If you just give impression without mounting, then the lab technician does mounting like this, because they don't know where the centric relation is. Next to patient, the upper is full denture and lower is implant supported over denture. The lab technician has made a wax rim. I did try-in. You can see the canting here. There's inclination. So I worked long and hard to adjust it. After my hard work, you can see that canting has been reduced, but I was not able to fully adjust it. You can see how the wax rim has changed. You can see it has become lower here and higher here. Here, it's the other way around. Mounting was done. Because the face bow mounting was done, we could ignore the inclined bridge form and align teeth in a parallel manner. Without face bow, this would not have been possible. Use of articulator and face bow transfer, I always emphasize to my peers and students that they need to buy this tool. I always emphasize on this. I always tell my peers and students. But people say this is arbitrary and it's impossible to find true hinge axis, but it's not about true hinge axis. We need to align teeth parallel to interpupillary line. This is the priority. This is an aesthetic issue. At chair time, you do not need to make significant adjustments on wax rim. By using articulator, you can simplify the process. Let's look at the process. This is a special patient. Because there's residual tooth here, the alveolar bone is going to be fuller, and on the other side, there's going to be a lot of alveolar bone resorption. Wax rim has been fabricated here. It's really full, although you cannot really tell on the image. If you look here, it looks very full. So I made a lot of adjustments. Orthodontics and VD were adjusted. We all learned how to adjust VD, and decisions were made. If you look at the form, a lot of removal has been made here. Wax rim for mandible has been adjusted. Mounting and face bow was used. When I mounted it, you can see that there is inclination. Despite my hard effort, there is canting. So I said one word. I told the lab technician to make this parallel. After that, this kind of result was achieved with the same VD. The height of the anterior side did not change, and only adjustments were made in the posterior side. Its parallel VD and CR bite was taken. By using face bow and mounting, the lab technicians can provide this kind of a result. You do not need to work and stress at chair side if you can do this. There was significant inclination and canting here. We can make this kind of wax rim at the lab. That is why I think face bow transfer is very important. There are advantages and disadvantages. It's very easy to do articulation. Once mounting guide is used, it's very simple and time can be saved. And you can evaluate a occlusal plane once again. When a problem occurs, it's very easy to track back your steps. As for disadvantages, there are none. Well, yes, the face bow may be a bit expensive, and it takes about $800 to $900 for assembly, but once you buy it, you can use it for a lifetime. There is a very little possibility of you losing it, so I don't think there's any downside to it. I think you need to buy this. Looking at semi-adjustable articulator, there are different options available. These are Hanau and Kavo articulators. This is really ancient and is no longer used these days, based on my understanding. Perhaps that was inappropriate to say. Kavo articulator and Kavo face bow assembly. Attex articulator and Attex assembly. You can use the right face bow for the articulator. When you're using semi-adjustable articulator, it's not going to be a problem. Once you try, I think Attex assembly is really excellent. There's no resistance, so I really enjoy it. Can I ask you a question? As I was providing lecture at Prosthodontics Division at Busan University, a lot of people talked about pop bow. I think it serves a similar purpose. Professor Lee, do you have experience with it? Yes, I did see it, but I do not have experience with it. I think it serves a very similar role like face bow. Is there any difference between pop bow and face bow? I was not really aware about pop bow, but a professor from Busan University came to Gyeongbuk University, and Professor Kim So-young uses pop bow. So I did see it and watch it in action. Pop bow is designed for people who do not have face bow. If you do not have a face bow, then this can be meaningful, but as I've shown you earlier, even if you try to find the right plane and use a fox plane, At times, there can be deviations. Even when you use pop bow, there can be error. This is expensive, but I think face bow is much better. Face bow may have more functions than pop bow. Thank you for your answer. I believe a lot of comments and questions have been raised in the real chat. Let's take a look. Smile again. Let's go prosthodontics on Friday. Professor Chung-hee Lee, good luck. Tolly is asking whether the articulator is essential because it's very uncomfortable. As for question and answer time, we're going to have it at the end of the lecture rather than in the middle. We're going to receive all the questions first and then address it. Q&A session will be held after Professor Lee's lecture. There are a lot of comments. MS Jung 0630. Good luck. I wish you the best. Thank you for your questions and comments. Once Professor Lee's lecture ends, we're going to address your questions during the Q&A session. I look forward to your avid participation, and their lucky draw coffee coupons will be sent to those who raise questions. Please carry on with your lecture, Professor. Moving on from face bow, let's talk about articulators. What kind of articulators should we use, and when and where should we use it? Review will be done on different types of articulators and articulator that is necessary for full denture treatment. We all know the different types of articulators. Simple hinge, semi-adjustable, fully adjustable articulators. The necessity of semi-adjustable articulators in full denture treatment is a well-known fact. Face bow transfer is possible. Centric relation needs to be accurate and stable. We need to get these data. It needs to be easy to adjust. We need to adjust the condylar factors and lateral movement. This should be possible. This is something that we all know. It's easy. In terms of choosing articulator, it should be easy to use. Once the lock is unlocked, it should be easy to adjust. Cavo or Osstem articulators are easy to manipulate and movements are easy to do. They're stable and there should be no breakdowns of such devices. Articulators should be cheap as well, and it has limitations, so we should not use something that is especially complicated. When adding mounting plate, in the past it was in the form of screw, but these days magnetic options are available and it's very easy to use. At times it breaks down and it needs to be of structure where you can easily access the different components. So once it breaks down, we do not just use it once or twice and throw it away. It is something that we use for 2 or 3 decades. In the case of Cavo, the company changed, so it is not easy to get your hands on the components. At our university hospital, we use a lot of Cavo products, but because some parts are unavailable, we are unable to use them. It was sold to Plan Mecca. This is a Finland company. Osstem also tried to purchase it. Yes, I am aware of that. It was sold to the other company. It would have been better if Osstem bought it. Then we would have been able to access different parts. Cavo is a very excellent company, but despite that, that happened. These days, we use a lot of Osstem articulators. Calibration is essential. Here, in the case of Cavo and Osstem, they can be used interchangeably. In the case of Hanawa articulator, that is not possible. Calibration is really important. In the case of optics, individuals can do calibration, so I think that's a very strong point. The centric relation movement should be accurate and lateral movement should be possible. Semi-adjustable articulators should be able to do this. I strongly believe that semi-adjustable articulators should be able to do lateral movements. If you take a closer look at articulators, there's Hanao, Dena, Kafo, and Atex articulators. Regardless of the articulator you use, you need to make full use of it. So where and when should we use articulators in doing full denture case? Articulators should be used at lab when artificial teeth are aligned, and when we need to try in after providing artificial teeth, you need to check the vertical dimension. Vertical dimension and centric relations are checked, and centric relation, interarch relations need to be checked. We need to check this on top of vertical dimension. By doing this, we can use articulators very meaningfully. I think this is also very meaningful in doing occlusal adjustments at chair side. Let me show you how vertical dimension is adjusted after try-in using articulator. So the artificial teeth are in. Try-in and vertical dimension check are done. There's different types and styles depending on different professors. This is not something that is of central focus today. 2 millimeters were reduced. This can be done very easily. If you have articulator, you can remove all teeth and use wax rim. If you have lab technician, that'll be better, but you can do it yourself easily. And then you can press upon it. After that, you can remove it. If there's indentation, then it's not accurate, but about 2 millimeters of vertical dimension can be reduced. In the case of this patient, it still seemed a bit high. About 3.5 millimeters were lowered, and the patient was satisfied with it. Aloe wax was used, and the CR bite was taken once again. It was set as 0, and mounting was done once again. You can do it at chair side within short period of time. You can do it very quickly and adjustments can be applied easily. Next, what is important is to check the interarch relations and CR. You need to do verification, and if done wrong, you need to make adjustment. And using articulators is a very good way. There's intraoral and extraoral method. This is intraoral method. The denture is placed intraorally, and there's a touch and slide method. When there's slight contact, you tell the patient to stay still and then remove your hands and have the patient move. But I cannot really tell the difference. Honestly speaking, I think this is false. I don't use this method, and I use the extraoral method. When I provide lectures, I tell my students that I do not use intraoral method. Extraoral method is very easy because you can use articulator, and the CR bite is taken with aloe wax, and you use the articulator. A little bit of space is created because wax was used. Still, because the hinge axis is right, it should be more in contact. Then this is not right. So you check once again. If it's not done right, you can do it over. In order to take CR bite, you need to remove all wax rim and artificial teeth. Articulators are especially good for this purpose. Wax rim has been removed and stop has been set. This is a different patient, and this has been adjusted. Aloe wax is used, and you check. Following the patient's original VD and VD in the articulator, it seems more in contact. The CR bite is taken again. After that, This is a model. If you check with the denture, it seems perfect, but on articulator, there's still space. So as it turns out, there should have been a space as was shown before because the CR bite is not correct. You can see it. If you cannot see it, it's right. It should be right when you cannot see it. If you can see it, then it's wrong. CR bite is taken once again. Mounting was done. And the artificial teeth are placed, and this was taken once again intraorally, and using this extraorally checking was done. You can see that the CR bite was correct this time around. CR bite was good. When you do checks like this, articulators are excellent. When you get things wrong, you can correct it very easily. Without articulator, it would have been impossible. So I think articulators are awesome. The importance of centric occlusion. This is very important. If the patient does not cooperate, this will be a problem and you need to check as frequently as possible. You need to check at try-in. If it's wrong, you need to explain to the patient and do it again. I think forming such relations with the patient is important. There are different factors related to articulator adjustment, condylar factor, and anterior incisor factors. I do not really like it, but because included in the textbook, I would like to talk about it briefly. Regarding condylar adjusting factor, you need to look at the records of lateral and occlusal surface, and this does not hold significant meaning in full denture cases. We can take anterior interocclusal records. I am wondering whether this is essential. I'm not sure whether this is appropriate, but we use average values. The sagittal condylar path is 33 degrees and lateral condylar path is 15 degrees. When things get difficult, interocclusal record for the anterior area is used. Hanau articulator is used for this. Condyle guidance. In the textbook says 25 degrees, but I use 30 degrees more frequently. In the case of 6 millimeters anterior guidance, you mark it here. 3 pieces of aloe wax are used. One is for the upper, the other is for the lower, and one is in between. So 6 millimeters are moved, and you need to check whether there's space. And then you press upon it. Once you do this, you can see that it is marked. The markings are made on the top and the bottom, and there's another layer in between. You look at the indentation and you put it intraorally and do softening. And then you guide the teeth. 6 millimeter protrusion occurs. This is slightly tilted. And then you put this on the articulator and condylar guidance is done. You can see that the indentations are made surely, and this is 35 degrees and this is 27 degrees. You need to mark it here. This is something that's quite rare. This was done intentionally to take images for a textbook. I normally use random numbers. What about you? I also use random figures. At times when this is necessary, I do take lateral and anterior bite, but I just use random numbers. Thank you. Next is anterior incisor factor. In the textbook, it says you need to adjust the incisor guiding plate, but I do not do it. I just set it as 0 and do occlusal adjustments. Next, I want to talk about occlusal adjustment at the clinic. Occlusal adjustment. This can be divided into lab remounting and clinical remounting. I learned this when I was an intern, and in the past I paid a lot of effort in lab remounting, but these days this is no longer necessary. I do not do this at all. I did it when I was an intern. In terms of clinical remounting, this is very important. I think this is essential. I tell my interns and students that this is very important and I have them practice it. I think this is crucial. This is absolutely necessary. And this should be done by a dentist using an articulator. When people talk about clinical remounting, my residents are excellent at it, but in general, people find it quite stressful. This is what I want to say. Should we aim for this kind of result? I've never achieved this kind of result. This was a hands-on practice. This is unnecessary. Let's take a look. I did not prepare a lot of details in terms of clinical remounting, but let's take a brief look. The recommendation is to use Elowax when taking records of centric relation. When we take a centric relation, people say we should not use a silicone type of impression material because it has less viscosity and resistance. So I use Elowax very frequently. Silicone becomes hard only when it dries, so there can be mobility, and that's why I recommend Elowax. Elowax has good viscosity and resistance. If it shows through, then with high possibility it has moved, so we need to make sure that it does not show through, and that is why I recommend Elowax. Next, after taking bite, you can do Facebook transfer and do articulation. You can do it like this. This is articulation for clinical remounting. Many find it very difficult, but I think we need to simplify our thought. You can do Facebook transfer again or use a remounting jig. You can use a remounting index. Also, you can use a random number. By random, I mean you can apply the CR bite on the articulator. If you mount it randomly, then you'll be able to use it meaningfully. When you use a semi-adjustable articulator and do occlusal adjustment, then you can get good results. So let's look at occlusal adjustment of centric relations. As we all know, we can use denture burr or a tool with stone, or you can use a Fisher burr. I use this at the last stage to make grooves. In general, I use this frequently. And for students and interns, I recommend this one because they will need to do a lot of adjustments. It's black on both sides. It's marked. For articulating paper, I use Acufilm. This is about 20 micron. It's about 23 micron thickness. I use the Acufilm used for crown and bridge restorations. I do not use the thick ones. I think it's very important to use this. If you use it, in the upper and lower, you can see there's barely any occlusion. You should not get stressed, and you can just start with occlusal adjustment. Let's look at the principles of CR occlusal adjustment. This needs to be applied to all working and non-working cusps, and the tip of the marked cusp should not be removed. We need to remove the bevel of the cusp and the ridge of the cusp where occlusion occurs. Adjustments should be done not as if digging, but we need to think of it as lowering what is protruding out. You can see that it's marked here. We're reading this. Cusp tip bevel, we need to observe it closely and make necessary adjustments. You also need to check the antagonist area. Cusp tip. This is cusp tip and bevel. Bevel needs to be removed with ratio of 1 to 1. And we need to make calculations as we make adjustments. When marking is significant, excuse me, if you find some markings significant, you can remove a bevel and make a cusp tip smaller. You need to make adjustments accordingly. There are big dots, small dots. I think this is sufficient from number 7 to 4. There's consistently markings, so it's okay. Next, once occlusal adjustment for centric relation is almost done, you move on to occlusal adjustments for the lateral movement. The principle of adjusting occlusal interference upon lateral movement are as follows. You need to mark the lateral movement and then mark the centric relation and use a different color articulating paper. For condylar guidance, it should be either 30 degrees, and we need to set it. The lateral condyle guidance should be 15 degrees. The lateral movement should be in red. And we need to use a articulating paper that is same color on both sides. And also, when checking occlusal interference upon lateral movement, we need to do it on both sides at the same time. When adjusting working side, you need to remove non-working cusp, and for balancing side, you need to remove the bevel accordingly with a red mark on the working cusp. Depending on the working direction of the cusp, the area where there is lateral movement interference is marked in red, and CR is shown in black, and we should not remove this. You need to make the red mark in a circular form and expand it, or you need to lower the protruding part of the ridge. You should not dig on it, but you need to make it feel like it is being more lowered. I think this is important. So if you just remove it, it's not going to be shown. I'm not going to talk about occlusal adjustment in depth. As shown, using red articulating paper, lateral movement is done, and black is reflecting the centric relation. If you look over here, the markings are not really clear, but as was before, the centric relation is shown clearly. The lateral movement feel is very rough. It seems like a movement is not done properly. If you provide restoration in this state, the patient will not be able to chew. CR is good, but the patient instinctively chews using lateral movement. That is why we need to adjust the lateral movement. We need to make adjustments on lateral movement. To give you a simple explanation, there's central groove and following the functional cusp bridge. From central groove on this side in red are all working side. Following the functional cusp ridge, we can draw a line, and everything in between is balancing. Everything on this side is working side. This is the criteria. If you take a look here, on this side of the functional cusp, it's working. In between, it's balancing, and on this side, it's working. If you look at the occlusal contact points, when we do movement, pattern of the working side is shown like this. On this side, the pattern of the working side will be like this. And on balancing, it's going to be like this, like a rotation. We need to look at the direction and make occlusal adjustments. On this side, it shows this kind of direction. If you take a deeper look, the cusp and the ridge move together, and not just the cusp tip. The triangle moves. The functional cusp is here, and it moves like this, working, balancing. Working and balancing. We need to think looking at the direction and make occlusal adjustments, so then things will become much more simple. I believe keeping this image in mind is very important. Look at this tangential line. If you look at this case, from start to finish, the angle is bigger compared with that side. As for this patient, movement is possible, but here, in the case of this patient, movement is not possible because in the initial phase, the tangential angle is too high. Here it's low, here it's high. That's why it's impossible. In this area, we need to focus on it and we need to make adjustments. We need to keep this in mind in order to get good results. A, B, C point are shown. And here, when guidance is done, working, balancing, working, yellow is balancing. We need to grind it slightly. We need to adjust it. When we do this, then we can get good results. We need to keep this in mind. As we perform occlusal adjustment, there are a lot of images, and I've done it. And this is a complete lateral movement occlusal adjustment. It's disastrous. It doesn't look good at all, but the patient was happy with it and used it well. Lateral movement, it's not about making it look pretty. We need to make sure that there's no interference, and smooth movement is very important. From CR, we need to make sure that occlusal contact points are made evenly on both sides. We need to make it accurate, and the number of markings are not important. From number 7 to 4, it needs to be widely distributed, and the guidance for the working side upon lateral movement, it needs to be smooth. And if lateral guidance on the balancing side is not possible, do not stress too much about it. If it is possible, then make adjustments. If not, then focus on the guidance for the working side and the lateral movement. So you can make slight adjustments, and then it will suffice. We need to make sure that the guidance for the working side guidance need to be smooth. That is most important. Then the patient will be able to use it properly. I think occlusal adjustment needs to be done several times. I do it upon delivery, and when patient comes back for follow-up visits, I also make occlusal adjustments. I do it several times. When patient finds it uncomfortable, I do it. By doing this, the patient will be able to adjust to the newly formed guidance plane, and the guidance angle becomes reduced every time we make occlusal adjustments. The patient can adapt to it better, then the patient can really feel comfortable with it. I've done up to 3 occlusal adjustments for one person, and if you do that, the patient can use it well. Regarding articulators, I've explained fully about how I use it. Regarding semi-adjustable articulators, this is absolutely necessary in prosthodontic treatment, and it's really useful in full denture treatment. If you don't have articulator, please try it, and if you have experience, then I'm sure you'll be able to get the sense that it's great. Trying it for the first time is the tough part. If you use it, then you'll realize how valuable it is. Taking the first step is the hardest part. But those of you listening to this lecture will be able to use it really successfully if you try it. Thank you for your attention. Thank you, Professor Lee Chang-hee, for the wonderful lecture. Professor, let's look at the Q&A questions on the chat screen. Earlier, a person asked whether articulator is absolutely necessary. Are there alternatives? No. You may use something that is more simpler compared to more complicated option, but whether or not using articulator is not an option. There's a significant difference. Mong Mung, I really agree that we need to take a close look at textbooks. Uja, Professor, you've used the wrong term for teeth. You need to say the term for human teeth rather than animals' teeth. Okay. Let's use articulators. When using articulator, what kind of preparation should I make to communicate with lab? In most cases, I fabricate separately. If there's nothing set in store, what kind of effort should I make in order to use the articulator properly? In my opinion, it's quite tough to say, but we need to cooperate with lab technicians, but we need to take the lead. If you say strongly, then the lab technicians will accept it. They try to work more and do things quicker, and we need to be responsible for the treatment result. We need to urge the lab technician to provide what is better. fabricating separately, I do it for crown and bridge. It's not a problem. But in the case of full denture, if the lab makes them separately, then you need to ask them to correct it. If they don't correct that practice, then you can move to a different lab. For full denture treatments, there are labs that provide such services. There are many such options, so try to find the appropriate lab. If you make a request, then lab will change. If you do not make such request, then nobody's gonna change. You need to make a request to the lab to use a semi-adjustable articulator, and you need to make sure that once Facebook transfer is delivered, the results should be reflective of that. So all information can be delivered via Facebook, so we need to bear this in mind. Or we can take images using our cell phone, and we can take an image of Facebook relation and send it to the lab technician. Yes, Facebook goes to the lab, but if we take images of patient face, then it can be better. Dutch, your lecture is very immersive, very good. This person really admires your lecture. Thank you. Let's use articulator. The Facebook transfer style varies significantly depending on articulator. Which product provides most convenient and accurate Facebook transfer? Which product do you recommend? I've mentioned this earlier. We used to use Cavo a lot. The Cavo Facebook earpiece is very significant. I don't understand why it is so big. I think a Westerner has bigger ears than us. These days, Cavo has certain issues, and now we've moved on to Artex. Artex assembly is very flexible. So I'm very happy using Artex. Artex is the articulator of your choice. It's easy to use. The advantages of articulators have been mentioned. Because in 2001, this has already been mentioned. It's raining. Actually, it's not. I just randomly thought that articulators were difficult, but I think this is a great opportunity to learn. Light, there's a different reference line for different articulators, and there's different reference points when doing Facebook transfer. We need to follow the manufacturer's instructions. Are they interchangeable? So there are different series from manufacturers, and there can be interoperability between that. But if manufacturer is different, then you will not be able to use it together. The reference points of the Facebook. In certain articulators, FH plane is used. In others, campus plane is used. There can be differences. In my opinion, I have similar opinion as you. The reference points that are used mainly are three. There are two in the back earpiece, and there's a vertical point in the front, but many people say that vertical indicators are not important. Perhaps you can use it, but I think it's best to use products from the same manufacturer. Nice to meet you. At times, you provide a treatment to 2 or 3 denture patients. How many articulators do I need to purchase? I probably should use the same model, right? I think this is a different issue. Actually, at our clinic, there's Artex and Cavo, and at the lab, there's those two products as well. If you have either articulator, it's the same. The lab should also have the according model. If it is calibrated right, it's fine. You just need one articulator to practice and to do try-in the oral cavity. So if you send that articulator, the lab can adjust following that. You do not need to buy separate models because there's interoperability between Cavo and Ottix. So it's not going to be a problem. I do not believe you need 2 to 3 articulators. You just need one. Even if it is just one. When mounting face bow, if you have multiple mounting ring, then it's fine. Yes, you just need multiple mounting plates. Denture life, I think this person provides a lot of denture treatment by the look of the ID. So when we randomly increase or reduce the dimension in the articulator, is it reflected in oral cavity the same? If we have found the true hinge axis and did it accordingly, then it will be reflected. However, it is difficult to find true hinge axis, and even when we find it, it can change. I rarely try to find true hinge axis. There can be a bit of difference, but this is not going to be a problem. There can be slight deviations, but it's not going to be an issue. And you can do occlusal adjustment. And because in the oral cavity, because there's soft bridge, it's going to be okay. However, in the case of crown bridge, then if there's changes, it's going to be reflected differently in oral cavity. Krista, 97. Due to long-term bad habits, there can be significant differences between CO and CR. In that case, how can we restore occlusion? Significant difference between CR and CO. I'm unsure by this question. This means whether there is significant CR/CO difference in full denture patient or in crown and bridge patients. Today, we're talking about full dentures, so let's focus on that. These days, the CR/CO positions are the same, regardless of what the patient originally had. We need to focus our treatment based on CR. We need to stick to CR if the patient habitually bites the wrong way. I came across a patient where the patient had weird occlusion, so I had to fabricate a new denture. However, we need to focus on CR when fabricating dentures. Unless we do that, we cannot assure success. Difference between CO and CR. I think this came to be because of using old denture and because of long-term habits. We need to make sure that it becomes a CR to CO. If it is difficult to do this, then we can fabricate a treatment denture to correct the occlusion and then provide final denture. That's what is written in the textbook. However, if the difference is not significant, you can provide prosthesis right away as well. Can do. From school days, I always have find it clinical remounting difficult. Please provide easy explanation. Clinical remounting and easy explanation. I think this is about understanding how to do occlusal adjustment properly. I don't think this question is about clinical remounting, but rather focuses on occlusal adjustments. Yes? As is with everything else, first time is the most tricky bit, and it's really difficult to take a first step, but please try it. Please refer to your textbooks or what is available and try it. If you try it, then the patient will be much more satisfied. You'll later think that you should have tried earlier. Regarding clinical remounting, we can make adjustments, then the patient will be able to use it much better. In order to do it easy and quick, it requires experience. You need to try it a couple of times. I'm sure you all know it, but it takes a lot of time for clinical remounting. If this is required, we assign at least 3 hours. If this can be done by the lab technician, then it's fine. But on the day of prosthesis delivery, if clinical remounting is required, then it is better not to deliver to the patient that day. Don't tell the patient. Tell the patient that it's going to be available the next day. I think you need to assign significant time. It's difficult to explain in detail about occlusal adjustment in clinical remounting. If possible, you need to stay away from functional cusp and focus on a non-functioning cusp and central fossa. You need to grind those areas. Escaping heat. So what is the limitation of occlusal adjustment in the clinical room? How much adjustment can we do for deviations of centric relations? This is difficult to say at this moment. There's an interesting slide that I have that I wanted to provide. If you don't have centric relation information and if you just have the information of patient's habitual bite, then you need to give up and do it over. 1 millimeter, it's not a major difference. If you feel that something's wrong, then the difference is much more significant, then you need to do it over. You need to do everything on the articulator, understood? Captain Americano. When you do occlusal adjustments for denture, what micron articulating paper do you use? This was already mentioned, so you use a shim stock. I use the best articulating paper that is really thin. Krista 97, can you provide explanation on lingualized occlusion? To talk about lingualized occlusion is going to take up a lot of time. In the next lecture, Professor Lee So-hyun is going to talk about it. When she talks about teeth alignment, she's going to talk about lingualized occlusion. So I'm going to deliver this question to Professor Lee and ask her to provide more detail. This is a question from Mr. Lee Hyuk on YouTube. So if the patient has a full denture in the upper and natural teeth in the lower, if there's canting in the lower natural tooth occlusal plane, do you adjust the natural tooth first and then fabricate the upper? There may be difference in terms of significance, but in general, how do you do it? The upper is full denture and lower is natural teeth. Do you do lower dentition adjustment first? It's a good question. The upper is full denture and lower is natural teeth. In that case, the occlusal surface is worn out. There can be a lot of sharp edges. You need to explain this to the patient and make adjustments. The sharp bits are smoothened. Doing this does not even require local anesthesia. If there is difference in occlusal plane, such as due to over-eruption, then I suggest providing crown prosthesis. In the past, I didn't do it, but then I ended up with some problems. If possible, we need to provide optimum results. There can be difference between patients, so we need to look at occlusal plane and make a decision. If possible, I do make adjustments. So when I do occlusal adjustments, I've talked about using articulators. I'm not sure about you, but if the patient has a full denture in the upper and natural teeth in the lower, when I adjust it in the articulator and then I move on to oral cavity, then at times it doesn't really fit. I've thought long and hard why that is, and this is because the lower is natural teeth. The alginate impression and the bite record of natural teeth can have some error. So when doing full denture cases for upper and lower, we align it, adjust it together so it fits, but with natural teeth, there can be error with the impression. If you're only treating one arch, such as upper full denture, then you always need to check once again. In the oral cavity, this is not done with the articulator. There's less movement in the upper. So you should check once again in the oral cavity because the lower teeth is natural dentition. There's no compensation of soft tissue. So when we do occlusal adjustment for the lower, I talk about paved and unpaved path. We need to make occlusal adjustment and make things smooth. If you do not make occlusal adjustment, it's going to be like walking on unpaved road, so it's going to be much more difficult. I think that's a very good idea.
훨씬 불편하지 않냐? 뭐 이렇게 이야기를 많이 해요. 감사합니다. 예.
Can do. If the patient has a bad biting habit, how can I approach it? This is slightly off topic. As you have mentioned a bit earlier, you can make provisional denture and wait. That could be a good idea. Yes.
네, 맞습니다. 예.
Next, Captain Americano. The upper is CD and lower is natural teeth. Because the patient has a strong occlusal force, a denture fracture continues to occur. This will be addressed at a future date. Like, if the patient has been using existing denture for long term and if occlusal adjustment is necessary, do you use articulator and mount it when you do occlusal adjustment? Can we just do it intraorally and achieve the same kind of results we can with the articulator? For me, I always use the articulator. When we look at existing denture, we need to check whether relining is necessary. You need to check the impression surface. If relining is necessary, you need to do that first. If everything is perfect, then you move on to occlusal adjustment. You need to mount it on the articulator. That is not an option. This is a must. Understood? Let's use articulators. So I don't have articulator that I used to use when I was a student. Which should I buy? The professor has mentioned ATEX. I think Professor Lee really likes ATEX. It's really convenient. He uses it really well. Young Mom 80, if the patient has a habit of biting down strong or grinding during sleeping, how can I improve the situation? Should I use the articulator here? I think this is a slightly off topic. So this is not about the denture light. Recently in digital system, there is a digital programs with a digital articulator function. In your perspective, how effective and accurate and practical is the digital articulator? I don't have experience using digital articulator. Realistically speaking, when we get the result of the CAD design, it can be significantly different from what you've had in mind. I personally think you need to really be able to see it. I do not use digital articulator yet. So you can use a CAD and ATEX together. So I just check. Digital articulator is used when we use digital systems. We use this for teeth alignment. After you get the actual prosthesis, then it is difficult to utilize the digital program. When we do try-in, this cannot be utilized, so you need to use the actual articulator and do mounting. Captain Americano. The patient bites down well when practicing, but when taking bite record, they bite down wrong, then it can be really difficult. Yes, that's true. In that case, you have the patient to bite down on cotton roll for about 2 to 3 minutes or 5 minutes. You need to do deprogramming and then proceed. Also, when guiding CR, we can have the patient stick one's tongue towards the back or retract the tongue. You need to have the patient to practice. Our star, at times, the markings are unclear in the articulating paper, so I use Vaseline. Is that a good idea? I think this person is using it in oral cavity. If you use Vaseline, you can get clear results. Perhaps this person is not using Acufilm. I think this person is using it in oral cavity. So if you use articulator, then you can get clear results. Next, can do. In the case of upper full denture and lower fixed prosthesis, Touch and slide. Wait 1 second. I think the question is how to adjust the touch and slide. Then you need to adjust the upper full denture. Touch and slide. So if there is a touch and slide, how can we adjust it? Touch and slide, this can be a major problem and difficult to address. In this case, you need to take a CR bite record and do it extraorally. You need to adjust it and then check once again intraorally. Understood? Thank you. Smile again. Professor Lee Chung-hee, thank you for the wonderful lecture. So this is the end of the questions in the Q&A session. Thank you for your wonderful answer. I can tell that you have a bit of an accent and you're really witty. Thank you for answering the questions. Yes, I do have accent. Thank you. I would like to express my gratitude to everyone who has participated in the chat. Now we will select the best question out of all the questions that have been raised in Prosthodontics on Friday. Those of you chosen as the best question will be sent the Busen Music Tiger dental set. I'm sure you have a couple of candidates, Professor Lee. I'm sure you want to give gifts to everyone, but you need to pick one person. There were really good questions, but I was so concentrated in the questions, so I couldn't take note of the IDs. So let's take a look at the different IDs and questions. If you look at the questions, let's use articulator. It's raining and light. Nice to meet you. Denture life. Krista 97. Can do. Has asked a question about clinical remounting. Escaping heat. Captain Americano, Krista 97. Lee Hyuk from YouTube, which has been raised by the administrator. Captain Americano can do light. Let's use articulators. Youngmom 80. Light, Captain Americano. I'm a fan. I'm a student listening in on your full denture lecture in this semester. I want to be a dentist just like you. I'm a major fan. So you have become a major mentor for the student. Can you choose one ID amongst different candidates? I think this person has chosen a very good idea, and I'll choose let's use articulator because I really like this. So congratulations, let's use articulator. A separate contact will be made to the person chosen. Those who won the coffee coupon event will receive text messages on Monday. Professor Lee, could you give a word of advice to our peers who have listened in on the importance of using articulators when fabricating full denture, watching Prosthodontics on Friday up until late? Thank you. Professor Cho, you really are my mentor. So I'm quite embarrassed to say as to what should be done, but as I turn over 60, I've come to think that we are really giving an immeasurable gift to patients when we provide a full denture prosthesis. After receiving denture or other kind of treatment from me, I can really see that they're much more happy and they eat much better. It's like restoring their health. Yes, we're increasing their quality of life. The medical side also saves life, but dentists also can provide health and happiness to our patients. I believe the dentists watching the program here today are really passionate, and with that passion, I hope you provide successful treatments to your patients that makes their life much more happier and meaningful. I think this is possible. Thank you for your attention. In other words, you want our viewers to become a wonderful dentist who restores happiness to our patients by providing an excellent treatment after listening in on these wonderful lectures. Thank you for coming here despite your busy schedule all the way from Daegu. Thank you for your wonderful lecture once again. Thank you. Dear viewers of Prosthodontics on Friday, today's lecture with Professor Lee Chang-hee was also meaningful and great. We were able to gain meaningful tips on using articulators. As for questions that were unanswered, please add your question in the comment. In the next lecture, Professor Lee So-yeon of Busan University is going to talk about full denture, choosing and aligning artificial teeth. Is it important in aesthetics and function? Thank you for staying with us up until late. Thank you. Good work, Professor Lee Chung-hee. Thank you.